So we start with diseases of endocrine system. I'll be covering the disorders of pituitary and adrenal gland and rest of the endocrine organs like thyroid and pancreas. They will be covered by other teachers. Starting with pituitary gland. Normal histology and physiology of pituitary gland has been covered in detail in first year. So we will not be discussing it in that much of detail, but just a brief revision so that you get some basic idea, and then we will start with pathological conditions of pituitary. So anatomy, as we know that there are two lobes of pituitary, anterior lobe, which is also called as adenohypophysis, and posterior lobe, which is also called as neurohypophysis. Adenohypophysis comprises the major chunk of pituitary mass, which is almost 80%. Then cells of pituitary, the cellular composition of both these lobes is different. Anterior pituitary, it has three predominant cell types, and these are uh, based on the various cytoplasmic staining characteristics of these cells. So there are acidophil cells which have pink cytoplasmic granules, there are basophil cells which have blue cytoplasmic granules, and then there are chromophobe cells which have little affinity for histologic stains. Then finally we have posterior pituitary. Here we have modified glial cells, and there are axon terminals of axon processes which are coming from the hypothalamus. Then the various hormones that are expressed by anterior and posterior pituitary. As we had discussed that there are three cell types histologically in pituitary, which are acidophil cells, basophil cells, and chromophobe cells. Further, they can be divided into six types of cells depending upon which type of hormone they are expressing. So we have in anterior pituitary somatotrophs which secrete growth hormone. Then we have mammosomatotrophs which secrete growth hormone and prolactin. Then we have lectotrophs which secrete prolactin. Then we have corticotrophs which secrete adrenocorticotrophic hormone and pro-opiomelanocortin, as well as melanocyte stimulating hormone. Then we have thyrotrophs which secrete thyroid stimulating hormone or TSH, and finally we have gonadotrophs which secrete follicle stimulating hormone and luteinizing hormone. So these are the six types of cells which secrete different hormones, and all these cells, these are situated in anterior lobe of pituitary. In posterior pituitary, we have just two peptide hormones. One is oxytocin and the other one is antidiuretic hormone, which is also known by the name of vasopressin. So after this brief introduction of the normal histology and physiology of pituitary gland, let's start with the pathology of pituitary gland. We'll start with clinical manifestations of various pituitary diseases. Any pituitary disease, this can present either because of hormonal alterations, which can be either excess or deficiency of pituitary hormones, or it can be because of mass effects, which are because of various pituitary diseases. So starting with hyperpituitarism. So this hyperpituitarism, this results mainly because of pituitary adenomas, which are benign tumors of pituitary. Then there can be hyperplasia, which is increase in mass of pituitary, and rarely we can have carcinomas of anterior lobe of pituitary. So these are the causes of hyperpituitarism. Amongst these, we will be discussing pituitary adenoma in detail when we discuss tumors of pituitary. Then hypopituitarism. This is caused by any process which leads to loss of pituitary tissue. This is because of destructive processes like ischemic injury, surgery, radiation, inflammatory reaction, and at times non-functional pituitary adenomas. Then finally, we can have mass effect. Mass effect is when the contents or the size of pituitary gland, it goes on increasing and it starts affecting or compressing the surrounding tissues which are in relation to the pituitary, and then it starts producing symptoms related to those tissues or organs. So the earliest radiological change that we can see in pituitary, say hyperplasia or adenoma, is cellular abnormalities which are associated with cellular tashica where pituitary is located. So they can be cellular expansion, they can be bony erosion, and they can be disruption of diaphragma cella. Then there can be visual disturbances. Visual disturbances associated with pituitary diseases are very characteristic. They lead to disturbances in bilateral temporal field of vision. This is because of compression of optic chiasm because it is related so closely to the pituitary, and the characteristic type of visual abnormality that is seen in patients with pituitary diseases is bitemporal hemianopia. Then there can be signs of elevated intracranial pressure like headache, nausea, vomiting. Rarely, acute hemorrhage can occur in pituitary if it increases so much in size so that uh, there is a particular type of clinical picture it appears which is called as pituitary apoplexy. And then finally we have diseases of posterior pituitary which present with either decreased or increased ADH and the symptoms related because of this. So these are the three broad clinical symptoms which result from diseases of pituitary. Hyperpituitarism we will discuss when we talk about pituitary adenomas, as this is the single most important cause of hyperpituitarism. So straight away we will start with hypopituitarism. Most cases of hypopituitarism they arise from destructive processes which involve the anterior lobe of pituitary. Hypopituitarism, if it is associated with posterior pituitary function, for example, ADH dysfunction, then it is almost always due to hypothalamus dysfunction. But it is if it is isolated, that is only the hormones of anterior pituitary they are decreased, then the cause is likely to be within the pituitary itself. So, starting with anterior pituitary causes, these can be tumors and mass lesions, which can go on increasing in size and they can compress and lead to atrophy of the normal hormone producing parenchyma of pituitary, leading to hypopituitarism clinically. Then there can be traumatic brain injury and subarachnoid hemorrhage. These are one of the most common causes of developing hypopituitarism. Then there can be pituitary apoplexy, which we had discussed, that if there is sudden hemorrhage in pituitary. Then there can be infections and inflammations of hypothalamus like sarcoidosis and tuberculosis, which destroy the hypothalamus and downstream signaling to the pituitary, again leading to hypopituitarism. Then in this type of condition, if there is infection and inflammation of hypothalamus, then the deficiency of both anterior and posterior lobe of pituitary hormones they will be seen as compared to diseases if they are located in the pituitary itself, where we will see only the disorders which will be because of the hormones of anterior lobe. Then there is a peculiar condition which presents with hypopituitarism. This is seen in obstetric patients and this is called as Sheehan syndrome. So what is this Sheehan syndrome? This is postpartum ischemic necrosis of pituitary. This is one of the most common causes of ischemic necrosis of anterior pituitary. What is the pathogenesis of this Sheehan syndrome? What happens in pregnancy is that the pituitary size it increases to twice the normal size, but the blood supply it is not increased proportionately. So already tissue of pituitary is in a state of relative hypoxia. So if there is a compounding condition like obstetric hemorrhage or shock happens in these patients, then it further aggravates the already present hypoxia and it leads to precipitation of infarction of pituitary tissue, and this leads to presentation of hypopituitarism. So this is a very important syndrome which is called as Sheehan syndrome, and this is seen particularly in postpartum setting. And then finally we have empty sella syndrome, which as the name suggests is when any condition where there is destruction of pituitary tissue which can be primary or secondary, and on radiologically the sella is seen to be empty. Then just a word about posterior pituitary syndromes. Amongst these we have diabetes insipidus and syndrome of inappropriate ADH secretion. In diabetes insipidus there is polyuria due to inability of kidneys to concentrate urine because of some disorder of ADH. Now this disorder can be either centrally located, that is in the pituitary, or it can be in the kidneys where it is called as nephrogenic diabetes insipidus. So in central type of diabetes insipidus, there is decreased secretion of ADH from posterior pituitary, whereas in nephrogenic type of diabetes insipidus, there is renal unresponsiveness to ADH levels. And on laboratory investigations, these patients, they have characteristically low specific gravity of urine. Then second is syndrome of inappropriate ADH secretion. This is characterized by hyponatremia due to high ADH, which leads to fluid retention. Although these patients have fluid retention and hyponatremia, but these patients usually do not develop edema. Uh, but the patient will have symptoms related due to hyponatremia. Then this can result because of ectopic ADH secretion, which can be seen in certain tumors like small cell carcinoma lung, then as a part of paraneoplastic syndrome. Then there can be certain drugs which the patient may be taking which increase ADH absorption, and finally there can be cerebral infections and trauma. All of these can lead to high levels of ADH, leading to fluid retention and hyponatremia. So we have discussed the various clinical syndromes, that is hyperpituitarism, hypopituitarism, and mass effects of pituitary diseases. Similarly, we have also covered the syndromes of posterior pituitary. So hypopituitarism we had already discussed. Now we discuss hyperpituitarism, and the single most important cause for this is presence of an adenoma in the anterior pituitary. So starting with the adenoma of pituitary. So this is the single most important cause of hyperpituitarism, but at times these patients can also present with hypopituitarism if the tumor is non-functional. But as we will see that most of these tumors, they tend to be functional, that is they secrete some kind of hormone. Now these adenomas of pituitary, these are further divided based upon which type of hormone these tumor cells they are secreting, and further they have though different kinds of clinical complaints depending upon which type of hormone they are secreting. Then this we have already discussed that these tumors, they can be functional or non-functional, although functional ones, they tend to be more common, and they usually secrete one type of hormones which are normally present in from the anterior pituitary, but at times they can have two or more hormones. Then there is a cutoff limit of somewhat arbitrary cutoff limit which is of 1 centimeter. If these tumors, they are less than 1 centimeter in size, then they are said to be microadenoma, and if they are more than 1 centimeter in size, then they are called as macroadenomas. Now most of the microadenomas, they tend to be clinically silent, and if they are diagnosed at the time of autopsy or at times workup for some other condition and they are incidentally found, then they are called as pituitary incidentaloma because they are incidentally found when investigating for some other condition, or at times they are identified at autopsy. Then non-functional adenomas, they tend to be larger in size at the time of presentation. Why is so? Because they are non-functional, so they do not have any presenting symptoms. So because of that, they go on increasing in size and they present quite late in the course of the disease when they start compressing the surrounding tissue and the patient presents with mass effect. And these tumors, they are found in adults, and peak range of incidence is around 35 to 60 years. Then morphology of pituitary adenomas. Grossly, these are soft tumors and are well circumscribed just like any benign tumors, and small tumors, they tend to be confined to sella turcica. Larger tumors, they can sometimes invade surrounding tissues where they are called as invasive adenomas. The large tumors, they can have areas of hemorrhage and necrosis, and non-functional adenomas, they tend to be larger in size. This is because it takes them a while to present clinically because they are non-functional, so they do not present with any hormonal disturbances, and it's only when they start compressing the surrounding tissues and having mass effect, only then they come to the attention of the patient and clinician. So on the right, we have the gross picture of a pituitary adenoma. We can see that it is a large tumor, definitely more than 1 centimeter. So it has to be a macroadenoma. It is well circumscribed, homogeneous, almost fleshy in color, and it has these small multiple dark brown areas, which are areas of hemorrhage. Also, you can see that as this tumor is quite large in size, so it is compressing the surrounding tissues. Then microscopy of pituitary adenomas. These are benign tumors. So they have uniform cells which are arranged in sheets and cords, and they have minimal connective tissue stroma, which helps uh, us to differentiate these from normal pituitary parenchyma. Then there is presence of uniform nuclei which have low mitotic activity as it is a benign tumor. Then cells, they can be acidophil, basophil, or chromophobe type depending upon the type of cytoplasm. So they are just like, they can be either of the normal cells of pituitary, which we had discussed earlier in histology. So any of these cells, they can be seen in a particular pituitary adenoma. So further subtyping on which type of adenoma it is, this is done on immunohistochemistry, where the various hormones that a particular tumor is expressing, provided that it is a functional one, then various antibodies, they can be used against these hormones. Clinical features, again, usually they present with hyperpituitarism, but at times they can present with hypopituitarism and mass effect if the lesion is sufficiently large in size. Then types of pituitary adenomas, as we have just discussed, that these pituitary adenomas, they can further be divided based upon which type of hormone they are expressing. So they can be lectotroph adenomas, which secrete prolactin, or they can be somatotroph adenomas which secrete growth hormone. Then they can be corticotroph adenoma which secrete ACTH, and then there can be non-functional adenomas. So starting with lectotroph adenomas, these are the most frequent type of hyperfunctioning adenomas, and histologically usually they have chromophobe cell type, and they also have tendency to undergo dystrophic calcification. Now this dystrophic calcification, it can range from psammomatous calcification to complete calcification of the tumor, where it is called as pituitary stone. So as these tumors, these are lectotroph adenomas, so they express prolactin, and the symptoms which will be seen in the patient, they will be related to the excess of prolactin, that is, they will present with amenorrhea, galactorrhea, and infertility in patients. Now these three symptoms, these are easily identifiable in female patients in reproductive age group, but if the patient is male or a female which is in post reproductive age group, then these tumors can be a little difficult to diagnose, as the classical features which are there because of prolactin, they can be absent in these patients. Then second most common type of adenomas are the ones which express growth hormone. These are called as somatotroph adenomas. Histologically, they can have acidophil or chromophobe type of cells, and these lead to gigantism in children and acromegaly in adults because of expression of growth hormone. And then we have corticotroph adenomas which expresses ACTH. These cells usually are of basophil type, and they will present with Cushing syndrome. Finally, we can have non-functioning adenomas which do not express any kind of hormone. So they will present either with hypopituitarism, because they will go on increasing in size and they will start compressing the normal pituitary tissue, leading to its atrophy, or they can present with mass effect. So these comprise almost 25 to 30% of total adenomas. They tend to be large at the size time of presentation, and they present with features of hypopituitarism or mass effect, and rarely they can cause pituitary apoplexy because of hemorrhage into the tumor tissue. Next are hypothalamic suprasellar tumors. These are located in suprasellar region, and amongst these we have gliomas and craniopharyngiomas. Gliomas we will be discussing when we talk about, or whenever we have the chapter on the brain tumors. Here we will be discussing only craniopharyngiomas. These craniopharyngiomas, these are thought to arise from vestigial remnant of Rathke pouch. These comprise about 5% of all of intracranial tumors. These have a bimodal age of presentation. One is in the adolescence and in children, which is around 5 to 15 years, and then there is second peak which appears around 65 years and beyond. Clinical features: the children or adolescents, they will present with symptoms of pituitary hypofunction because of mass effect, and adults, they will present with again headache and visual disturbances. Genetics: these tumors, they are said to be associated with abnormalities of WNT signaling pathway along with beta catenin mutations. Then gross picture of craniopharyngiomas. These are lobular and cystic tumors with areas of calcification, and cysts, they can have thick brown yellowish fluid which has been compared to machine oil appearance. So on the right we have a gross picture of a craniopharyngioma. You can see that it is a well circumscribed tumor and it is solid cystic in appearance. Microscopy. Microscopically, these tumors are divided into two distinct variants. One is adamantinomatous craniopharyngioma and the other one is papillary craniopharyngioma. Now, these adamantinomatous craniopharyngiomas, these are seen only in children, whereas papillary craniopharyngiomas, they are almost always observed in adults. So, starting with adamantinomatous craniopharyngioma, these are usually observed in children. Now, what these tumors they have microscopically is that they have a fibrous stroma, which we can see in the photomicrograph on the right, where this fibrous stroma is depicted by the black asterisks. Then they have nests of squamous epithelium, which we can observe in the right half of the photomicrograph. Now, these squamous cells they have peripheral palisading, that is, the cells they are arranged perpendicularly to the basement membrane, and their nuclei they are also arranged perpendicularly to the basement membrane, which is depicted here by the presence of this black colored arrow. Now, as we come towards the center, these cells they have a mesh-like appearance, which is called as spongy reticulum, which is marked here by the red asterisks, and also they have compact lamellar keratin, which is called as wet keratin, which is depicted by a yellow asterisk in this picture. So this is the appearance of adamantinomatous craniopharyngioma, where we have nests of squamous epithelium, which as we come towards the center, they have a mesh-like appearance or spongy reticulum type of appearance, and also they have compact lamellar keratin, which is also called as wet keratin. Now these tumors they can also have degenerative changes like cystic degeneration, they can have dystrophic calcification, and they can also have xanthogranulomatous inflammation. Next is papillary craniopharyngioma. These are called so because of their papillary appearance. These are usually observed in adults. On low part, we have broad papillary structures with cauliflower-like morphology. If we go higher up, then we have solid sheets of well-differentiated non-keratinizing squamous epithelium, which lines these fibrovascular cores. And unlike the adamantinomatous craniopharyngiomas, these tumors they lack calcification, keratin, and cysts. So if we see in this photomicrograph on the right, we can see that there are broad fibrovascular cores which are highlighted by this yellow colored asterisks, and these fibrovascular stromal cores, they are lined by strips of non-keratinizing squamous epithelium, and one area of this squamous epithelium I have highlighted with this black colored asterisks. So this was all about diseases of pituitary gland. We discussed that the anterior lobe and posterior lobe of pituitary, they are anatomically and physiologically as well as pathologically they are different. The diseases of anterior lobe of pituitary, they are different as compared to posterior lobe, which are different. In anterior lobe, if there is any kind of disease in pituitary, it can present with hyperpituitarism, of which pituitary adenoma is the single most important cause. Then there can be symptoms of hypopituitarism, which can result because of any uh, destructive process which destroys the pituitary tissue. And we in specific talked about Sheehan syndrome, which is seen particularly in postpartum setting. And finally, some of the tumors of pituitary which can present with mass effect, which can have the symptoms of the organs which are located in relation to the pituitary, like there can be features because of raised intracranial pressure, or there can be visual disturbances. Particularly, the important one which is seen or which is highly characteristic of pituitary diseases is bitemporal hemianopia. Then we have these suprasellar tumors, amongst which we had craniopharyngioma, which has bimodal uh, age of presentation. Two types are seen microscopically, adamantinomatoous and papillary, and these we discussed. And the cause of hyperpituitarism, which are adenomas, that we have also discussed. And we also saw that different types of adenomas, they all will not present similarly. They can express various types of hormones. Different adenomas, they can present different hormones. Some can express growth hormone, some can have prolactin presentation, some can have ACTH expression. And because of these different hormones that can be secreted by different adenomas, the presentation of pituitary adenomas, they will be different in different patients. So next we will start with adrenal gland. Again, histology and physiology of adrenal gland, they have been discussed in detail in anatomy and physiology classes. So I will be giving you just a very brief review so that then we can start with pathology of adrenal gland. So as you know that these glands, they lie at the upper poles of both kidneys. They are approximately 4 gram in weight and they are larger in children. Histologically, these glands, they have two distinct zones, cortex and medulla. They have different cellular composition, and just like pituitary, these two layers, that is cortex and medulla, they express different chemicals. So cortex, it has three layers. If we go from outside to inside, we have zona glomerulosa, fasciculata, and innermost layer is zona reticularis. So zona glomerulosa, these comprise of ovoid clusters of clear small polygonal cells, and they express mineralocorticoids. Zona fasciculata is next up. It has cords of lipid-rich cells which secrete glucocorticoids and sex steroids. And finally, we have the innermost layer, which is zona reticularis, which comprises of cords of small blue cells which secrete glucocorticoids and sex steroids. So these are the three different layers and different hormones of cortex. Coming on to medulla, it comprises of chromaffin cells. Chromaffin, which have affinity for chrome salts. So these cells, these are arranged in nests with faint basophilic cytoplasm. Uh, they are also called chromaffin cells. Why? Because the catecholamine granules which are secreted by these cells of adrenal medulla, they react with chrome salts and they undergo oxidation and lead to brown color. Hence, they are called chromaffin because they have affinity to chrome salts. They can also undergo oxidation in light. Now, the cells of medulla, it is derived from neuroectoderm and it is a component of neuroendocrine system. It secretes catecholamines, that is epinephrine and norepinephrine, and the major metabolites that are formed from these two hormones, that is epinephrine and norepinephrine. These are vinyl mandelic acid, that is VMA, then we have homovanillic acid and metanephrine and normetanephrine. So as we can see that the hormones that are expressed by cortex, these are mainly mineralocorticoids, glucocorticoids, and sex steroids, whereas adrenal medulla, it expresses epinephrine and norepinephrine. So because of that, the various diseases of cortex and medulla, they have different presentations. Starting with disorders of adrenal cortex hormones, they can have either hyperadrenalism or we can have hypoadrenalism. Hyperadrenalism can further be uh, Cushing syndrome, where there is increased uh, amount of glucocorticoids, or we can have hyperaldosteronism where we have increased amount of mineralocorticoids, and finally we can have adrenogenital or virilizing syndromes where we have increased quantity of sex steroids. Then adrenocortical insufficiency, it can be of primary or secondary type. Primary if the cause is located in the adrenal, or it can be secondary. Primary can further be of acute and chronic type. The chronic adrenocortical insufficiency is also known by the name of Addison disease. Starting with Cushing syndrome, this is called so as it was first described by Dr. Harvey Cushing. This results because of elevated glucocorticoid levels. Causes, they can be endogenous or ectogenous. Ectogenous is the most common cause because of various glucocorticoids which are administered to treat various conditions. Then they can be endogenous causes which can be ACTH dependent or ACTH independent. ACTH dependent is when there is presence of an ACTH secreting pituitary adenoma, and this is the most common cause for Cushing syndrome of endogenous type. Almost 70% of uh, causes of endogenous Cushing syndrome are because of some pituitary adenoma which secretes ACTH. Then there can also be rarely ectopic ACTH production as a part of some paraneoplastic syndrome as seen in the case of small cell carcinoma lung. Then the tumors, the Cushing syndrome, it can also be ACTH independent where the cause is located within the adrenal. So these can be because of adrenal adenomas, adrenal carcinomas, and primary adrenal cortical hyperplasia. So these are the different causes of Cushing syndrome, that is ectogenous or iatrogenic, where some drugs they are administered to treat some condition, and as a side effect there is presence of elevated glucocorticoid levels leading to Cushing syndrome, or they can be endogenous. Endogenous can be if the cause is located in the pituitary in the form of some ACTH secreting pituitary adenoma, then they are said to be ACTH dependent because nothing is wrong with the uh, adrenal, but because there are high levels of ACTH, so that stimulates adrenal leading to high levels of glucocorticoids. Or they can be ACTH independent where pituitary and hypothalamus they are all right, but the adrenal it has some kind of either cortical hyperplasia or adrenal adenoma is there which leads to expression of large amounts of glucocorticoids, and this leads to uh, Cushing syndrome in these patients. So the most common causes amongst ectogenous and endogenous is ectogenous, and in endogenous the most common cause is ACTH dependent, and that too because of presence of an ACTH secreting pituitary adenoma. Morphology, if the Cushing is because of ectogenous cause, then there is atrophy of zona fasciculata and zona reticularis layers because these are now not stimulated by ACTH, and if there is endogenous Cushing, then it is enlarged by cortical hyperplasia. If uh, there is hyperplasia of the cells of adrenal, or there can be presence of some benign or malignant tumor. And finally, the clinical features of Cushing syndrome, this you are well versed with, that is there can be presence of moon faces, buffalo hump, central obesity, purple stria, proximal muscle weakness and muscle loss, and various other abnormalities like glycosuria, hyperglycemia and polydipsia, etc. Then lab diagnosis of Cushing syndrome. Two investigations that can be done to ascertain the diagnosis of Cushing syndrome is one is estimation of 24-hour urinary free cortisol, which is will be increased, and secondly there will be loss of normal diurnal pattern of cortisol secretion. Now, further localization of the cause of Cushing, whether it is ectogenous or endogenous. If it is endogenous, then of which type? That can be done by measuring ACTH levels and by doing a dexamethasone suppression test. Here, urinary excretion of steroid, particularly 17-hydroxycorticosteroid, is done, and this is done after administering a low dose and a high dose of dexamethasone. So, based on these two parameters, we can identify where the cause of Cushing is. If it is pituitary dependent Cushing or ACTH dependent, then ACTH will be high as the problem is in the pituitary. There is some ACTH secreting pituitary adenoma is there. So ACTH will be high. When we do dexamethasone challenge of low dose, there will be no reduction in urinary excretion of 17-hydroxycorticosteroid. But if we give a high dose of dexamethasone, then there will be reduction in urinary excretion of 17-hydroxycorticosteroid. Now, if there is production of an ectopic ACTH hormone, say by some tumor, for example, small cell carcinoma, then ACTH production it will be high because the tumor cells they are secreting ACTH, but there will be no reduction in urinary excretion of 17-hydroxycorticosteroid by administering low or high dose of dexamethasone. Then finally, if the tumor is ACTH independent, that is the cause of Cushing syndrome is located in the adrenal itself, then the levels of ACTH they will be low because of feedback by the adrenal, and there will be no reduction in urinary excretion of 17-hydroxycorticosteroids by either low or high dose of dexamethasone. So this is how we can differentiate where the origin of Cushing syndrome is there in a given patient. Next is primary hyperaldosteronism. Chronic excess of aldosterone is seen in these patients and it can be primary or secondary. Primary is there if there is high aldosterone and because of that there is low renin, or it can be secondary if there is high renin in the kidney because of some condition and because of the feedback there will be high aldosterone. Then we will be talking mainly about primary hyperaldosteronism. So the causes can be bilateral idiopathic hyperaldosteronism. This is the most common cause of primary hyperaldosteronism, almost 60% of the cases, and these are because of bilateral nodular hyperplasia of adrenal. Then there can be adrenocortical neoplasms which express aldosterone, and then there can be glucocorticoid mediable hyperaldosteronism. This is seen in certain families where there is a genetic defect which leads to production of hybrid steroids, and this makes this aldosterone responsive to ACTH. Then there can be secondary hyperaldosteronism where the cause will not be in the adrenal but in the kidney, where there is increased production of renin. This can be because of decreased renal perfusion, for example, in the case of renal artery stenosis or nephrosclerosis, or hypovolemia or shock, or at times in pregnancy because of elevated plasma renin substrate. So all these lead to increased level of renin, which in turn elevates the levels of aldosterone. Morphology: grossly, the adrenal, it will be bright yellow on cut section, and microscopically either we can find diffuse hyperplasia, that is, there will be diffuse enlargement in the size of adrenal, or there can be adenomas of adrenal which are secreting the aldosterone. Clinically, hypertension is synonymous with the primary hyperaldosteronism, and hypokalemia in a significant subset of patients will be observed, although there can be some patients which may not have hypokalemia. This is diagrammatic representation of primary hyperaldosteronism. Most common causes idiopathic hyperaldosteronism, which is because of idiopathic bilateral hyperplasia of adrenals. Then there can be second most common cause, which is presence of adenomas which express aldosterone, and finally there can be rare causes which are production of hybrid steroid hormones, where the aldosterone, it can become responsive to ACTH. So because of any these three causes, ultimately there is high level of production of aldosterone, which activates renin-angiotensin pathway, leading to increased sodium reabsorption and ultimately resulting in hypertension in these patients. So we have discussed about states with adrenocortical hyperfunction, that is Cushing syndrome and hyperaldosteronism. Now let's discuss adrenocortical insufficiency. One is primary adrenocortical insufficiency, which can further be divided into acute and chronic type, and then there is secondary adrenocortical insufficiency. Now, primary adrenocortical insufficiency, whether acute or chronic, will be when the cause of this adrenocortical insufficiency is located in the adrenal itself. So, in primary acute adrenocortical insufficiency, this can happen because of some kind of stress in patients who are already in chronic adrenocortical insufficiency, and this stress precipitates acute adrenocortical insufficiency in these patients, as there is already low reserve of adrenocortical hormones in these patients. Then if there is rapid withdrawal of exogenous steroids, so already the body's adrenal cortical cells, they are suppressed, so the body is unable to cope with sudden withdrawal of these exogenous steroids. Then there can be massive adrenal hemorrhage. This can be seen in newborns with prolonged or difficult delivery, or in patients with DIC, patients on anticoagulants, and in patients with overwhelming bacteremic infection, particularly which is called as Waterhouse-Friderichsen syndrome. So we'll just talk about this Waterhouse-Friderichsen syndrome. Uh, this is seen in overwhelming bacterial infections, particularly in Neisseria meningitidis, but it can also be seen in Pseudomonas, pneumococcal, Haemophilus influenzae, and staphylococcal infections. But classically, this has been associated with Neisseria meningitidis. So, patients with this overwhelming infection of Neisseria meningitidis, these patients, they develop rapidly progressive hypotension, DIC, widespread purpura, rapidly progressive adrenal insufficiency, and massive bilateral adrenal hemorrhages. On the left, we have a picture of a patient who has massive purpura on her face, whereas on the right we have again the adrenals which are seen in the case of Waterhouse-Friderichsen syndrome. We can see that the adrenal cells, they have become shrunken, and there is massive hemorrhage into the parenchyma of adrenal. Then primary chronic adrenocortical insufficiency, which is also called as Addison disease. This is an uncommon disorder and it results from progressive destruction of adrenal cortex. Causes, they can be involvement of adrenal because of lymphomas, sarcoidosis, fungal infections, adrenal hemorrhage, autoimmune adrenalitis. However, four most important causes of primary chronic adrenocortical insufficiency are autoimmune adrenalitis, very important cause which is tuberculosis, then there is AIDS and metastatic cancers. So all these can lead to Addison disease. Morphology will depend upon the underlying cause, that is, if any of these different diseases they are involving the adrenal, so the changes of them they will be seen. For example, if there is a development of Addison disease because of involvement of adrenal by tuberculosis, so we will be seeing granulomas with or without presence of caseous necrosis. uh, Clinical features, these will develop when more than 90% of cortical parenchyma is lost. Features, they will begin as vague complaints of weakness, fatigue, gastrointestinal complaints, and characteristically, there will be hyperpigmentation of skin at sun exposed and pressure points like knuckles, elbows, neck, and knees. Now, this hyperpigmentation will develop in these patients because of high levels of pro-opiomelanocortin. And later on, these patients will also develop hyperkalemia, hyponatremia, volume depletion, and hypotension. The next is secondary adrenocortical insufficiency. This is because of disorders of hypothalamus and pituitary which reduce output of ACTH. These are different from primary adrenocortical insufficiency where the cause of adrenocortical insufficiency was located in the adrenal itself. Here, adrenal is absolutely fine initially, but later on, because of involvement of hypothalamus and pituitary, which have reduced levels of ATH, so it is unable to stimulate the adrenal, and ultimately, it also becomes markedly decreased in size. But the initial site of involvement of uh, disease is not in the adrenal itself. That is why it is called secondary adrenocortical insufficiency. Also, prolonged exogenous steroid administration can also suppress ACTH and can cause adrenal insufficiency. What is different in secondary adrenocortical insufficiency is that hyperpigmentation of Addison disease, which is primary chronic adrenocortical insufficiency. It is absent because the level of pro-opiomelanocortin they are not elevated. Morphologically, the adrenals they will be moderately to markedly decreased in size. The cortex will be thinned out, but medulla will be preserved because that is not the site of production of the hormones which are involved in development of secondary adrenocortical insufficiency. So this was all about various adrenocortical hormonal disturbances and pituitary disorders. In next class, we will talk about various tumors of adrenal, both cortical tumors as well as medullary tumors. This various these hormonal defects or disturbances of pituitary as well as adrenal. I have not gone in a lot of detail because these have already been covered in physiology. If you need clarification on any of these topics, you can refer to your standard textbooks.